everyone. I'm Swati Varma, one of the mentors of StudyMEDIC, and here we bring you a new series of RRR. Just like before, in order to help you guys to achieve more stable results, to improvise your results, we have started discussing important questions of the last year recalls, especially the latest ones. So through 10 SBAs and 10 EMQs, in this video, I will cover the antenatal care module. These questions will be based on the latest exam tested questions. So let's start as usual with the quote of the day, that strive not to be a success, but rather to be of value. Don't read or study just to achieve or clear your exams, but study to improvise yourselves, to make yourselves better clinicians and better persons. So now let's start with 10 SBAs first, which are basically based on the latest exam tested questions. Let's deal with the first one. So Charlotte, a 25-year-old woman, is referred to the genetics clinic due to multiple medical issues and a significant family history of similar symptoms. Now, she has a history of recurrent shoulder dislocations, chronic joint pain, and hypermobile joints. On examination, her skin is soft, hyperextensible, and bruises easily. Also, she reports a recent cardiology workup for mitral valve prolapse. Fundoscopy revealed no significant abnormalities, but just an increased risk of retinal detachment. Her mother and maternal aunt have similar issues with joint hypermobility and cardiac concerns. So here they want us to tell the most likely diagnosis which is coming to our mind. So yes, out of these 5 options, the correct answer is B, that is Ehlers-Danlos syndrome. Now let's analyze. In this video, I will also be explaining the approach which you should have to the questions. Like option analysis, one by one, if we look, why Ehlers-Danlos syndrome is the correct option. So if we look here, EDS is actually a group of connective tissue disorders, the main features of which are joint hypermobility. Joint hypermobility will reveal in the form of various manifestations like recurrent dislocations, like as for example, here shoulder dislocations history is given. Then another characteristic which is given here is skin hyperextensibility and fragility, which leads to easy bruising and soft, stretchy skin. Also, tissues are fragile, which leads to mitral valve prolapse, increased risk of retinal detachment. So all these features we are getting here. Also, it has got a genetic component, Ehlers-Danlos syndrome. So family history is also supportive of this diagnosis. So that's why this leads us to believe that Ehlers-Danlos syndrome would be the single best answer. Now let's see why other options are incorrect here. Because of joint dislocation, it sometimes might come to our mind that, yes, why not Marfan syndrome? But Marfan syndrome will be characterized by other prominent features like tall stature, they will definitely give, or arachnodactyly, aortic root dilatation. These all are the features which are very much pathognomonic of Marfan syndrome. So these are absent here. Also, lens dislocation is more characteristic of Marfan syndrome. Joint hypermobility, if they are giving as such, then it is more suggestive of Ehlers-Danlos as compared to Marfan's. Next, osteogenesis imperfecta. It's associated with brittle bones, recurrent fractures, and blue sclera. Noonan syndrome is characterized by short stature, distinctive facial features are there like Turner syndrome, and cardiac defects. So these typical features which are given here are not as such characteristic of Noonan syndrome. And if we look at Stickler syndrome, it involves basically the retinal detachment risk, which is found here. But other features like hearing loss, midfacial hypoplasia, and cleft palate, they are more suggestive of Stickler syndrome. So these are absent here. Hence, the most single best answer becomes Ehlers-Danlos syndrome. Okay. So these are the key learning points. We came to know that what features are suggestive of Ehlers-Danlos, and we should be very clear how to rule out other options of Marfan's, osteogenesis imperfecta, and others. Coming to the next question, a 28-year-old woman, gravida 2 para 1, presents at 40 weeks of gestation with severe polyhydramnios. While reading the question, we should be very careful as to what is the age, what is the parity. We should start picking up the key points. Age, parity, gestation, and then what is the presenting thing. So here she is full term, 40 weeks, severe polyhydramnios. Next, her SFH is measuring 46 centimeter, which is significantly above normal for term pregnancy. Now, fetus is unstable. She's not reporting any contractions. She's not in labor. So what is the most appropriate next management? So considering that she's full term now and fetus is, unstable lie, it's not fixed. So the best option here will be cesarean section. Why? Because severe polyhydramnios patient is presenting to you at term with significantly increased SFH and abnormal fetal lie. So here there is high risk of complication if we allow her for induction of labor, means vaginal delivery. Risks like umbilical cord prolapse, because fetal malpresentation will be there. If we keep her on expectant management, then also she will be at risk of developing other complications. So here the best option will be that of cesarean section to prevent the complications and ensure a safe delivery for her. So induction is inappropriate because of increased risk, as we discussed. Some of you might think that sugar testing, why not sugar testing? Let's first test her sugar. But yes, of course, sugar testing will be a part. But as of now, immediate delivery is the priority. Testing for glucose abnormalities would have been relevant earlier in pregnancy. Here, if suppose we test for sugar and if it comes high or if it comes slow, our treatment won't be different. We should go for such options which would alter our treatment or alter our approach. Here, our approach would be should be the immediate delivery. Sugar testing won't alter our approach, won't delay or won't, we won't delay our management just based on the sugar results. Now, amnio reduction may have been the correct answer if she would have been in earlier stages of the pregnancy, so as to alleviate symptoms of polyhydramnios, to provide her more time so that fetus can get mature. But here she's already at term. What's the need for amnio reduction? Obviously, expectant management is also not a good option here. So the best option stays cesarean section. Is the safest delivery option, especially when the fetus is not in cephalic presentation at term. All right. So here the key learning points are these. Now there in talk, there is a table. Just I have added for information here that whenever polyhydramnios is detected on ultrasound, what should be the approach? Detailed ultrasound for fetal abnormalities. This is especially if it is found at prior gestational ages, not at term, but if it is found on ultrasound in earlier gestational ages, then what should be your approach? You should do detailed ultrasound, do maternal investigations, and consider antenatal steroids if like she is at risk of preterm labor. All right, now let's come to the third question. Isla, a 30-year-old woman at 39 weeks of gestation, she expresses concern during her antenatal visit after learning that her friend's baby was diagnosed with early onset GBS infection. She herself tested negative for GBS at her 36-week screening. Somehow she underwent screening at 36 weeks. She has no other risk factors. Now she is concerned and asks, like, what is the approximate incidence of EO-GBS infection in neonates born to those women who tested negative for GBS colonization? So here, since she has been tested negative, so the risk becomes less than 1%. So the incidence of early onset GBS infection in neonates born to mothers who test negative for GBS colonization is actually very low, at less than 1%. So testing negative for GBS, it indicates a minimal risk of neonatal infection because the mother is not carrying the bacteria in her vaginal or rectal flora. So Isla's individual risk remains low, although her friend's experience, based on her friend's experience, because her test result as such demonstrates no colonization. Now let's analyze the other options. Why 2% is incorrect? Because it is the approximate risk in GBS positive women who do not receive intrapartum antibiotic prophylaxis. But it doesn't apply to GBS negative women. 5%, 10%, 20%, all are overestimations. So, screening for GBS, it allows targeted prophylaxis as to protect the neonates born to colonized mothers. So, we can reassure Isla as her personal risk remains quite low. Coming to next question. Eleanor, a 30-year-old woman, she attends her 36-week antenatal appointment with her midwife. Her pregnancy has been uncomplicated thus far with normal blood pressure and no gestational diabetes. She is low risk. Midwife, following up with midwife on examination, the midwife identifies that the fetus is in a breech position. She is otherwise asymptomatic and there are no signs of maternal or fetal distress. So what is the most appropriate course of action for the midwife? Now here we would like to analyze the options one by one. Monitor fetal position, refer to consultant care, schedule an elective cesarean section immediately at 36 weeks, advise attempting ECV at the appointment, ECV by midwife, would it be feasible? Reassure her that spontaneous cephalic version will happen. Obviously not. So out of all these options, the best option seems to be B, that is refer to consultant care for further management because the patient is with the midwife. Why this is correct? Because breech presentation at 36 weeks, best would be to refer to consultant obstetrician so that all the options of management of breech can be discussed with the lady. She can be offered right now ECV because the best time to perform is 36 to 37 weeks. So it's best that she is referred to consultant so that this option can be provided. Or suppose if she doesn't want to go for ECV, planned cesarean section, option of planned cesarean section can be discussed with her. Planned vaginal breech delivery may be discussed with her if she is not ready for ECV or if ECV fails. Consultant referral will ensure timely expert assessment as well as delivery planning. So, monitor fetal position at the next visit, no. Schedule an elective CS immediately at 36 weeks, obviously no. Advise attempting ECV at the appointment. It should only be performed by consultant or experienced obstetrician, you can say. And reassure that spontaneous cephalic conversion would occur, very unlikely. So here the key learning points which you have to keep in mind is that at all point of time, we should keep in mind that the patient is presenting to you in which setting. Here we have to keep our eyes and ears open that yes, here the patient is presenting to midwife. So we can't jump to provide ECV because ECV should be provided in safe setting. We should keep ourselves open that at which gestational age patient is presenting. So patient is presenting at 36 weeks, which is very appropriate for ECV. So like this, we can have an approach by paying extra attention to each and every word of the question. Coming to the next question, Mrs. Priya Sharma, a 28-year-old woman at 32 weeks of gestation. She presents for her routine antenatal visit to you. She reports feeling fatigued, short of breath, experiencing dizziness over the past 2 weeks. She denies any recent infection or bleeding. Her antenatal history uncomplicated, and she has been compliant with her pregnancy supplements. Now, blood tests have been performed, which reveals hemoglobin quite low. So this is catchy. 32 weeks, hemoglobin quite low, MCV 72 FL. Now, don't worry. The normal values are always provided in exams. So normal MCV as such is 80 to 100 femtoliters. So here MCV is low. Microcytic. MCH again is 22 picograms. Normal MCH is 27 to 32 or 33. So here MCH is also low. So hypochromic. So microcytic hypochromic anemia. The patient is presenting with microcytic hypochromic anemia. Immediately we start thinking about either iron deficiency or thalassemia. So now ferritin again is 6 microgram per liter. Now, ferritin value should be mostly above 30 and below 10 is definitely deficiency in iron storage. So what is the most likely diagnosis? So since microcytic hypochromic picture, ferritin is also low. So we start searching for iron deficiency anemia first. And here we get iron deficiency anemia. So the single best answer here will be A. It's the most likely diagnosis due to the patient's pregnancy, which increases iron demands, and her symptoms are also suggestive of the same. Also, iron deficiency is the most common cause of anemia in pregnancy. Especially she is presenting in third trimester here when fetal iron requirements are at its peak. Okay. So like this, one by one, we can exclude. Vitamin B12 deficiency, why it is unlikely? Because usually it presents with macrocytic anemia and here it is not. Also, neurological symptoms, paresthesia, all these things are not given. Folate deficiency is again presenting with macrocytic anemia, unlikely here. Hemolytic anemia, as such, hemolytic anemia will always present to you with symptoms of breaking RBCs. Elevated bilirubin, jaundice, reticulocytosis, all these things are not here. No syndrome which might be suggestive of hemolytic anemia. And last one, aplastic anemia. In aplastic anemia, they will give you some findings which are suggestive of reduction in all blood cell lines, reduction of WBC count also, platelet count also. So since there is no evidence as such anywhere in history or test results, so aplastic anemia is also excluded. Hence, the most feasible answer is iron deficiency anemia. So these are the key learning points which we learned from this question. Yes, in management, oral iron supplements will be the first line treatment because right now she has got time. If she's having severe anemia or she's very advanced into her gestational age, then things like blood transfusion, or for severe anemia, or if oral therapy is not feasible, she is not compliant, then IV iron can be resorted to. Coming to question number 6, Miss Emily Harper, a 32-year-old RHD negative woman, underwent an emergency CS at 36 weeks for placenta accreta. Now, during surgery, she experienced 3000 ml of blood loss and required 1000 ml of intraoperative cell salvage blood to stabilize her hemodynamics. 3000 ml would have been life-threatening. 1000 ml IOCS blood was given to stabilize her, RHD negative. Newborn was confirmed to be RHD positive. No history of anti-D prophylaxis issues was noted during pregnancy. Anti-D was given, there was no issue. Obstetric team needs to determine the appropriate dose of anti-D, how much to administer post-operatively. What is the correct dose of anti-D here? Now here, in view of intraoperative cell salvage, the recommended anti-D dose comes out to be 1500 international units. So RHD negative women with significant blood loss, especially when intraoperative cell salvage is used, they are at high risk of feto-maternal hemorrhage. So anti-D at a dose of 1500 units is the recommended prophylaxis to cover the potential exposure to the RHD positive fetal red cells. Now 1500 will protect against approximately 15 ml of fetal red blood cells, or you can say 30 ml of whole fetal blood, which is sufficient for routine feto-maternal hemorrhage risk in cases of intraoperative cell salvage. So what if we look at other options? 100 international units, is it sufficient? It would just cover only about 0.5 ml of fetal RBCs. So this will be insufficient. 250 international units again will be suitable for smaller FMH volumes. 500 international units will again cover only up to 5 ml of fetal red cells. So it will fall short. Now 1250, although it will be close, but it will not fully meet the standard guideline recommendation. So if we look at BCSH guideline, that is British Society of Hematology guideline, in that it is recommended that 1500 international unit of anti-D is standard for large FMH risk, either major hemorrhage or use of intraoperative cell salvage. Ideally, a Klehor-Betke test should be performed to quantify FMH if it is suspected to exceed 15 ml of fetal red cells. What should be the timing of administration? Anti-D should be administered within 72 hours of delivery or suspected FMH. And why IOCS increases the feto-maternal hemorrhage risk? It is re-infusing the salvaged blood. And salvaged blood also may contain the fetal red cells. Hence, maternal exposure will happen. So, to prevent future complications, it is necessary that we administer 1500 units of anti-D. Okay. Coming to the next question. Miss Laura Bennett, a 32-year-old, is attending her routine anomaly scan at 20 weeks of gestation. The scan reveals mild ventriculomegaly at routine anomaly scan, okay? She underwent CVS at 12 weeks due to advanced maternal age, and the results confirmed no chromosomal abnormalities. Somehow she was advised CVS, but on CVS everything was normal. She has no history of infections or autoimmune diseases, and her previous pregnancy was uneventful. Now, what's the most appropriate next step in the management of this patient? Now, ideally, CVS should not alone be offered at 32 years, but somehow she was offered and it showed normal chromosomal analysis. So, considering the next step in view of her ventriculomegaly is the option A, that is fetal echocardiography. Why? Because here the ventriculomegaly is mild, between 10 to 15 mm. But always ventriculomegaly, whenever is reported, we should consider that it can be associated with congenital heart defects. Even if chromosomal abnormalities are absent, the next step which should come to our mind is exclusion of congenital heart defects. So fetal echo is the next step to assess for any structural or functional cardiac anomalies, because standard TIFA or standard ultrasound may miss subtle cardiac defects. Now let's analyze other options, why they aren't correct. Amniocentesis, not indicated because already CVS has been carried out to look at the chromosomal abnormality, chromosomal picture. So CVS is normal, so amniocentesis will also be normal. Then MRI of the fetus might come to our mind that ventriculomegaly is there. Why not let's confirm whether ventriculomegaly is there through fetal MRI. Although it will provide a detailed visualization of CNS, but it is typically used to analyze those ventriculomegaly that is getting worsened or that is moderate to severe, or if further clarification of any CNS anomaly is required, which is significant, moderate or severe. But here, ventriculomegaly is mild. Why not repeat ultrasound in 4 weeks to confirm our findings? Follow-up ultrasound is important for monitoring ventriculomegaly. Definitely it will be done. But it doesn't provide additional information about associated cardiac defects. It will be done after 4 weeks. So ruling out of cardiac defects needs to be done earlier. So right now you will do fetal echo. Later on, you will repeat ultrasound in 4 weeks, but only after ruling out associated cardiac defects through fetal echo. Why not TOT screening? It is used to evaluate congenital infections, and it might come to our mind that toxoplasmosis is associated with ventriculomegaly, or cytomegalovirus may be associated. So why not this? But in the absence of any maternal symptoms or known risk factors, as such, TOT screening is not offered as the first step. The first step which is offered is fetal echocardiography. Why? Because mild ventriculomegaly has a known association with congenital heart defects, even in cases without genetic or infectious causes. And fetal echo will only allow the detailed cardiac assessment. Now, one extra thing, that is sequential approach to ventriculomegaly. Suppose if you are getting any ventriculomegaly question, what should be your sequential approach? Step 1 will obviously be exclude chromosomal abnormalities first. First, you will see whether CVS or amniocentesis, chorionic villus sampling or amniocentesis has been performed or not. Then you will evaluate for associated anomalies first, like fetal echo for congenital heart defects. Then you will choose follow-up imaging, that is repeat ultrasound, and on repeat ultrasound, if ventriculomegaly is persisting, worsening, getting more severe, then fetal MRI. And TOT screening will only be done if infections are suspected. Regarding prognosis, it often resolves or remains stable, and outcomes are favorable if no associated anomalies are identified. Now, coming to the 8th question. Miss Charlotte Green, a 35-year, presents to emergency with sudden onset of difficulty breathing, urticarial rash, and hypotension, approximately 15 minutes after eating a meal at a restaurant. She was treated promptly with IM adrenaline, IV fluids, and antihistamines, and her symptoms began to improve. Now, the medical team suspects anaphylaxis and want to confirm the diagnosis. Now, this again has been asked multiple times. So, most appropriate test to confirm the diagnosis of anaphylaxis is, yes, it is mast cell tryptase. So, let's have a look. It's the most specific test actually for confirming anaphylaxis. Now, tryptase is something which is released into the bloodstream during mast cell degranulation, which occurs in anaphylaxis. So, you take blood sample at 1 to 2 hours first after symptom onset for the peak levels, and then we repeat at 24 hours to establish the baseline levels. Elevated tryptase levels will support the diagnosis of anaphylaxis, especially when correlated with clinical findings. Let's have a look at other options. Serum IgE as such is non-specific and is not diagnostic of acute anaphylaxis. Skin prick, it is useful for identifying allergen sensitivities, but it is contraindicated in acute settings and doesn't confirm anaphylaxis as such. CBC, CRP, they will show something or the other suggestive of allergic reaction, but obviously they are not diagnostic for anaphylaxis again. They can't be used as a diagnostic test, right? So the best thing, the key learning points become the best test for anaphylaxis stays at mast cell tryptase. First sample 1 to 2 hours after onset of symptoms, and second sample 24 hours later. Now coming to the second last SBA, 34-year-old Gravida 3 Para 2 is undergoing routine antenatal care. At 32 weeks gestation, a detailed ultrasound is performed, which confirms placenta previa. Placenta previa itself means placenta covering the internal os. Now, the scan has also raised suspicion of placenta accreta spectrum due to irregular placental lacunae and absence of retroplacental clear zone. Now, the patient is asymptomatic, no vaginal bleeding or contraction. What is the most appropriate management for this patient? Now, as soon as placenta accreta spectrum we get, we see that the diagnosis should be confirmed, multidisciplinary team settings should be there. So things like that are not given, but the options point towards like when will you plan delivery. So one by one, if we look at the options, the D option seems to be most feasible here in this case. That is elective C-section at 34 to 36 weeks with multidisciplinary planning. So this stays the single best answer. For placenta previa without placenta accreta, delivery would have been planned at 37 to 38 weeks so as to reduce the risk of preterm birth and hemorrhage. But when placenta accreta is suspected, according to flowchart, we plan the delivery at 34 to 36 weeks, flowchart of GTG, to balance the risk of hemorrhage also and fetal maturity also. Sufficient maturity will be achieved. So multidisciplinary team setting will be sought for, and also delivery will be, steroid coverage will be done, and delivery will be planned at 34 to 36 weeks. Multidisciplinary approach is a must because it requires a specialist team involving obstetricians, anesthetists, urologists, and interventional radiologists. And ideally, preparations for hysterectomy should be made and blood products should be kept available if we are planning a C-section for placenta accreta. Now, why not other options? Immediate delivery, we will reserve for cases with active hemorrhage or fetal compromise, which is as such not present here. Weekly ultrasound monitoring alone is insufficient for confirmed placenta previa major with suspected PAS. Why? Because weekly ultrasound monitoring won't yield any results. Definitive treatment will be the planning of delivery with multidisciplinary approach. Elective C-section at 37 to 38 weeks, we can't delay this much so as to avoid complications. And vaginal delivery as such is contraindicated in placenta previa due to the risk of catastrophic hemorrhage, of course. In placenta accreta, never ever, or even in placenta previa, we can't allow for vaginal delivery. So the key learning points are the timing of delivery, tertiary care center, multidisciplinary input, steroid coverage, of course. Now coming to the last SPA. A 35-year-old woman, gravida 3 para 2, presents at 34 weeks for a follow-up in the antenatal clinic. She has a history of one previous cesarean section for failure to progress. A detailed ultrasound at 28 weeks shows grade 4 placenta previa, again complete placenta previa. Repeat scan at 34 weeks confirms persistent previa with no evidence of placental migration. Charger. The cervical length is 18 mm and she is asymptomatic. Cervical length is suggestive that she might land up having premature delivery. And she is asymptomatic with no vaginal bleeding or uterine contractions. However, Doppler reveals normal fetal growth, but marginally reduced AFI. Now, she is concerned about the timing and mode of delivery, as well as the risks to her and her baby. So what is the most appropriate plan of action? Now, here, the options are immediate C-section, weekly monitoring with ultrasound, or expectant management until 37 weeks without intervention, or hospitalization, steroids, and cesarean delivery at 34 to 35 weeks. Administer steroids and plan an elective CS at 37 to 38 weeks. So since here there is no, where it is written that placenta accreta is suspected, so here we can allow up till 37 to 38 weeks after administering steroids. So through these two questions, we basically come to know about the timing of delivery. Multidisciplinary input, you should remember. Administering steroids, you should remember. Multidisciplinary input, especially in accreta cases. Steroids in both accreta cases also and placenta previa cases also. The timing of delivery is very important. Please keep in mind 34 to 36 weeks there and 37 to 38 weeks here. Indications, there are no indications for early delivery. You should also be on the lookout that whether they have given anything suggestive of requirement of early delivery, like whether fetal growth restriction is there, or any significant Doppler abnormality is there, or any bleeding is there, hemodynamic instability, then of course you won't wait. But here we can wait after steroid coverage. Now let's come to EMQs. Number one EMQ, this set of EMQs here, it is based on female genital mutilation, that is FGM. 45-year-old woman complains of heavy menstrual bleeding from couple of months now. She is really worried and wants to get a solution. On asking history in detail, she told she had history of FGM done when she was 17 years old and she has been never been sexually active. Now, FGM is there. This is not a case of pregnancy, but a case of 45-year-old woman presenting with FGM with heavy bleeding. Now, of course, HMB has been there for a couple of months now. How to go about choosing the single best option out of the extended matching question? So data recording is of course mandatory for all women identified as having FGM. But let's look for a better option if it is there. Data recording mandatory for all women? Yes. Document the details with anonymization in the HSCIC dataset? No. Clitoral reconstruction here, no point. Here, no point of red book. Police won't be informed because she is 45. Again, clitoral reconstruction, no point of performing. Document the details without anonymization in the HSCIC dataset. Document the details of the type of FGM in medical records. Medical records, no. Documentation is to be done in HSC-IC dataset. Offer de-infibulation at 20 weeks, no point. Re-infibulation, CS now, these all are irrelevant options. So how to filter out your options first? So either data recording mandatory, document the details, A, B, G, or H. Out of A, B, G, or H, how to choose the best one? So the best thing will be to record in HSC-IC dataset, because recording is always done in this. And we will always record without anonymization. We don't have to, we have to mention her details. Without anonymization, we can't, we have to put her name and all the demographic details so that the data isn't duplicated next time. Next time she again comes, we might land up having again documenting the same case. So that's why we have to do it without anonymization. We have to mention her name and details. So this seems to be the best option. That is answer G. Now, just to have a look, just to make things clear, there are many confusions as to which option to choose in this scenario. So first of all, make it clear that you have to explain the law on FGM, documenting the discussion and referring her to information provided in the health passport. Provide interpreter if required, offer referral for psychological assessment and treatment, offer specialist referral as appropriate. Like suppose she's coming with dyspareunia or anorgasmia or things like that, then sexual health. If she's coming with urinary retention, then urology. Here she's coming with HMB, you will look out for option if it is given that refer to gynae services also. Along with documentation, you will refer her to gynecology services also. But in context of FGM, what needs to be done? Clinical assessment needs to be done. And since she hasn't been sexually active, so need for de-infibulation is dicey here. But record data in accordance with HSC-IC FGM enhanced data set. This is a must. This should include age at FGM, country where it was performed, date of entry to UK, and past history. Okay, so reporting to social service or police is only required if a related child is considered to be at risk. So no mention of any child here. So the best option is recording data in HSC-IC FGM enhanced data set without anonymization. These are the other things which are routinely asked, like when to refer to psychosexual services, when to go for clitoral reconstruction. So here, while psychosexual therapy may be beneficial, first step will be the risk assessment. Always choose risk assessment over referral to psychosexual services because that holds priority. Reporting to police only under the age of 18. Social services may be part of the management plan if any children you find might be at risk, or if you find that any individual is vulnerable in the family or at risk of undergoing FGM, then only refer to social services. Coming to the next question with the same set of options, a 20-year-old from Somalia is a primee seen for booking in antenatal clinic at 16 weeks. She underwent ultrasound which revealed a singleton, appropriate for gestation, routine blood investigations were done, hepatitis C is also done. Now, she has history of FGM and examination is revealing type 3 FGM, that is de-infibulation. Documentation is complete. Now next, what to do? She is 16 weeks. Documentation is complete. So here, regarding documentation, no need to choose anything. Regarding clitoral reconstruction, no need to choose anything. Red book doesn't come into picture until delivery has already been done. Police won't be informed because she's 20. So the single best option seems to be offer de-infibulation at 20 weeks or at delivery it can be done. But out of here, the single best answer would be de-infibulation at 20 weeks. So this is the routine antenatal, intrapartum and postpartum care which is offered. Very essential to go through all the tables and appendix which is given at the end of FGM GTG. Okay. Now 17-year-old. As soon as 17-year-old comes at 11 weeks, found to have FGM, you will look for two things. Whether she is having any acute complaint acute complaint of like urinary retention or anything like that. If any acute complaint, then go for first relieving her complaint. Next, if there is no acute complaint, then regarding her age, first and foremost, you have to search for police. Less than 18 years and no acute complaint, look for any police option. Inform the police if it is there. You have to go with that. So FGM is illegal to arrange, it's an offense, and if confirmed in a girl under 18 years of age, reporting to the police is mandatory. And also know that this must be within 1 month of confirmation. Within 1 month, okay? Now, a 20-year-old from Somalia is a primigravida, 36 weeks gestational age, 36 weeks. She has come to emergency with heavy bleeding PV. Her ultrasound is revealing a singleton appropriate for gestational age with placenta covering os. Now, she was due for elective CS after 1 week. At 37 weeks, her cesarean section was due, but right now she is coming with heavy bleeding PV. She has history of FGM and examination reveals type 3 FGM. No documentation done about deinfibulation. So now what to be done? So right now she is having heavy bleeding. So her urgent management needs to be done first. So we will look for any option which says cesarean section, which is here. Now she has got two options. If suppose she comes to you in a setting at daytime where a consultant or an obstetrician who is well versed in deinfibulation or who has been dealing with such cases, who has been performing deinfibulation is there with you, then you can perform cesarean section and peripartum, it can be done. Deinfibulation can be done immediately after C-section also. But since she has come in emergency, we are not certain that deinfibulation, preparation for deinfibulation is there or not, because ideally she had to be done after 1 week. Then preparation for deinfibulation would have been there. But right now in emergency, we are not certain whether she can be deinfibulated or not after C-section. So the better option is refer for deinfibulation later to FGM clinic. Right now, you will place her for C-section. So both these scenarios I have kept. Like in women for whom intrapartum deinfibulation was planned and emergency C-section is done. So if feasible, discuss the option of perioperative deinfibulation after safe CS, or if it was not, you are not able to perform during cesarean section, after cesarean section, then follow her up in gynae outpatient or FGM clinic so that deinfibulation can be offered before a subsequent pregnancy. Now next EMQ regarding administration of routine antenatal anti-D prophylaxis, which statement is not true? So here sample should be taken for routine antenatal 28 week. It is true. If using 2-dose regimen, minimum dose of anti-D 250 is recommended at 28 and 34 weeks. This option seems to be false because 500 unit is recommended at 28 and 34 weeks if we are using 2-dose regime. So option G is false. Regarding other options, there is good evidence that antenatal anti-D immunoglobulin prophylaxis using either a single large dose at 28 weeks achieves a significant reduction in the incidence of maternal sensitization. If using 2-dose regime, you should give 500 at 28 and 34 weeks. Or single dose, you can give 1500 between 28 and 30 weeks. If they ask out of 2, which is preferred? So because of cost effectiveness, single dose regimen is more cost effective. Okay. You are having a patient, Mia. She is involved in a road traffic accident at 11 weeks without any vaginal bleeding, but with trauma to her abdomen. It's her second pregnancy. Blood group is O negative. Her anti-D level is 4 international units per ml. She is having anti-D in her blood. She has anti-D levels of 4 units per ml. Her husband is heterozygous for D positive. What is the most appropriate next step in management? So now, you will think she is having vaginal bleeding and trauma to the abdomen. Ideally, she should be given anti-D, but no, anti-D levels are already there in her blood. So she won't require you won't immediately administer her anti-D. Husband is heterozygous for D antigen positive. So now the next best step will be to determine the fetal genotype by CFF DNA. So the best answer here is D. You won't straight away jump to administering. You will look for fetal. Is there any option which checks for fetal genotype? So you will look for that. So since this woman has already been sensitized, no purpose of giving anti-D right now. You will check father. Father is heterozygous at this point. So best is to know the fetal status of antigen. Look here, anti-D antibodies, test father. If he is heterozygous, then non-invasive prenatal diagnosis in the form of FFDNA. If baby is found to be positive, you will proceed like this. Otherwise, nothing needs to be done. Now, for any potentially sensitizing event, RHD negative, previously non-sensitized women should receive a minimum dose of 500 intramuscular within 72 hours of the event, regardless of whether she has already received RAA-DTP at 28 weeks. Any additional dose is guided by a test of maternal blood for feto-maternal hemorrhage. The dose calculation is based on which formula? So here, based on which formula, we have to choose out of these, because here this is writing about formula. So we all know that 125 units of anti-D immunoglobulin is given for every ml of fetal red cell. So the correct option is K. So where it is necessary to give additional dose, the dose calculation is based on 125 units of anti-D per ml of fetal RBCs for IM administration. So we should give this. Now, next set of questions, the last three are based on SGA, a very important new guideline. Mrs. Elaine at Gravida 2 underwent first trimester combined test. PAPE was found to be 0.3 mom. She also has a history of small baby in her previous pregnancy. What would you advise her? Now here we know PAPE, less PAPE is now a high risk factor. So we have to offer her EFW and uterine artery Doppler at 18 to 24 weeks. But one thing more has been added in this guideline, that low PAPE is an independent risk factor for preeclampsia and placental associated anomalies also, abruption, IUGR. So here start aspirin also. According to recent guideline, the new GTG, PAPE is low, start aspirin and anomaly scan including this. So the best option is H. So look, women with a low PAPE should be offered aspirin. Low PAPE means either below 5th centile or below 0.4 mom. Okay, both you should know. And yes, PAPE less than 5th centile is a high risk factor. So uterine artery Doppler along with the EFW at anomaly scan is required. Next question. Mrs. Elaine was referred for growth scan at 28 weeks in view of suspected SGA by her midwife on SFH. Midwife performed symphysiofundal height. She found it to be low, so she was referred for growth scan. Now, how would you monitor her if her EFW on ultrasound was less than 3rd centile? Less than 3rd centile with any Doppler, whether normal or abnormal, is FGR, not SGA. Less than 3rd centile is always FGR. So how to monitor FGR? We will monitor FGR with EFW is to be done fortnightly and umbilical artery Doppler is to be done weekly. Okay. So umbilical artery Doppler weekly and EFW fortnightly is the ideal monitoring regimen, especially for early FGR cases. So you should be very clear, first of all, what is early FGR, what is late FGR. Biometry is to be performed now every 2 weeks in FGR, and weekly you will perform umbilical artery Doppler. If there are any other concerns, then more frequent monitoring like 2 to 3 times weekly. If you find any umbilical artery abnormality, then 2 to 3 times weekly, otherwise weekly. Now the last EMQ. Next monitoring scan of Mrs. Elaine was carried out at 30 weeks. This showed absent end diastolic flow in umbilical artery, AEDF. Now what next? If you find AEDF, first of all, look at gestational age. If she is 32, you can consider delivery. If she is 34, you will definitely recommend delivery. But right now she is 30. So you will offer her more frequent monitoring through ductus venosus and computerized CTG. So if we look at the options, the best would be monitor minimum twice weekly with ductus venosus and computerized CTG. So the option correct answer is L. Please remember, AEDF or REDF in umbilical artery requires more frequent monitoring through twice weekly with CCTG and or DV. If she is between 24 to 26 weeks, you will provide individualized care. If she is between 26 to less than 29 weeks, you will offer her CCTG and or DV. If DV A wave is absent or reverse, deliver, or STV less than 2.6 millisecond, deliver. Between 29 to less than 32 weeks, again, you will monitor her twice weekly with CCTG and or DV and deliver if DV A wave is absent or STV is less than 3 millisecond. And in any case, please look if REDF is there, that is reversed end diastolic flow, deliver by 32 weeks. And if absent end diastolic flow is there, consider from 32 weeks and deliver by 34 weeks. So that's in brief regarding early FGR, how to time your delivery. In absent diastolic flow or reversed end diastolic flow, you will offer CS. In umbilical artery PI more than 95th, you can perform vaginal delivery. In all these cases where DV A wave is absent, STV is less than the threshold values, there you will offer her CS. So these were 10 SBAs and EMQs which were based on the latest exam. They were the latest exam tested questions, and hope this helps. All the very best for all of you. A very happy learning. So that's all for today. Thank you.